Welcome all those joining online to the College of Psychiatrists of Ireland event to mark World Mental Health Day 2022. I'm Dr. William Flannery, President of the College of Psychiatrists. The purpose of this evening is to discuss how we should respond to those in a severe mental health crisis. I believe it comes down to what we want for a family member, a significant other, or even ourselves if acutely unwell due to mental illness. The part of the response we're exploring this evening is the legal framework for that response, how it works now and how we want it to work. How it works now is that involuntary mental health treatment is currently legislated under the Mental Health Act 2001. This applies to only a small and highly vulnerable minority of the patients, those with the most severe and debilitating episodes of psychosis, mania and severe depression form the majority of patients who receive life-saving treatment under the Act. There is new legislation on the way. A draft Heads of Bill for a new Mental Health Act was published last summer with a lot of major changes proposed. And this week saw the publication of the pre-legislative scrutiny report on the draft Heads of Bill to amend the Mental Health Act. This report contains 19 recommendations from the Subcommittee on Mental Health to inform the reform of the Mental Health Act 2001. So now is the time for us to say what we want, whether it is we as a College of Psychiatrists, as other professionals working in the area, or as those with the lived experience of mental illness, but especially we as a society and as a country. As this is an event for the general public, I'm delighted to know we have a broad range of people attending, including many health professionals, and also have an excellent panel. This topic, though, can be distressing. So if you become distressed and need urgent help, please contact your out-of-hours GP service, or in an emergency contact 999 or 112, or attend a hospital emergency department. Or if you want to find out more about mental health supports, you can call the HSE Your Mental Health Information Line, or talk to your GP or current mental health provider. Finally, you can also call the Samaritans on their free phone. This advice on what to do will be shown on the screen at the end of the webinar. So thank you everyone for joining here this evening, and I now will hand you over to Miss Priscilla Lynch, who is a highly regarded health journalist and clinical editor, and who has very kindly agreed to chair this meeting, and we are very grateful.
Thank you very much, Dr. Flannery. This is a very welcome opportunity to discuss a topic that we don't discuss enough, and that it's often shrouded in mystery and stigma and fear among the general public. So I very much welcome this opportunity today to discuss these topics with our expert panel. We're going to look at involuntary mental health issues, detention, treatment without consent. Do we respect people's human rights enough? How are services functioning on the ground? And specifically, we're going to look at the existing Mental Health Act. How does it work on the ground for patients, for clinicians, the proposed changes under the draft Heads of Bill, and also our responsibilities under international law, particularly human health rights. So first of all, I'm going to introduce the panel and let them tell us a little bit about themselves. Dr. Martin.
I'm Dr. Norman Martin. I'm Consultant General Adult Psychiatrist and Vice President of the College of Psychiatrists of Ireland.
June.
I'm June Shannon. I'm a medical and health journalist.
Burr.
I'm Burr Grogan, the Policy and Research Manager with Mental Health Reform, a coalition of charities.
John.
My name is John Farley. I'm the Chief Executive of the Mental Health Commission. We regulate mental health services in Ireland. We register them and inspect them. And we also oversee the tribunals for people who are involuntarily detained to ensure that they're lawfully detained and to protect their rights.
Frank.
My name is Frank Brown. I'm a social worker and I've worked in the area of mental health since 1994, both in the UK and here. And once the Part 2 of the Mental Health Act was established, I was one of the first authorised officers, that is one of the applicants, professional applicants that can make an application for a recommendation for somebody to be involuntarily admitted to hospital. And perhaps I've done about 100 involuntary admissions or assessments for involuntary admissions. Sometimes the person agrees to treatment.
Kate.
I am Kate Mulkerrins. I'm the Executive Director of Legal with An Garda Síochána, with responsibility for legal and human rights as well.
And finally, Anne-Marie.
Marie Nocton, I'm a GP in Cork, and I've been working in the area of homeless services in Cork City for about 8 years. So I have been involved in many of these, I suppose, involuntary admission assessments as well. And thank you for having me on.
Thanks very much. Before we go to our panel and debate the particular issues at hand, just know that if you're watching from at home, you can enter your questions into the Q&A function and we will come back to them later on. But first of all, we're going to watch 2 videos by Rosie Wilson and Brian McNulty about their own personal experiences of using mental health services. And then I'm going to ask the panel for their thoughts on such.
I think you need to go into hospital. I said to her, there's nothing wrong with me. I'm fine. I don't need to go into hospital. Despite all the concerns of my family, I had no insight. So she said, I'm Brian McNulty. I'm the co-chair of Refocus. I was admitted with psychotic illness on 7 occasions between 1974 and 1990. The last 2 times I was admitted, I had to be compulsory detained. Now, that's interesting in itself, in that as I was learning more and more about my mental illness, my condition continued to become more and more of a concern. And the last 2 times I needed to be committed. In other words, there was no reasoning with me. And that's because I was in a very psychotic state. Following my 3rd admission, I went to college and studied as a social worker and graduated in social work. It was a little bit tricky because I had a psychotic episode just before graduation, and I was wondering, was the college going to allow me to graduate? So I went my case was put in front of a kind of committee and they allowed me graduate despite the fact that I had a serious mental illness. My work was actually very helpful to me in my own recovery because I was dealing with distressed people as a social worker. So I was learning about myself, and I suppose my own buttons were being pressed. Now, I didn't deal with that obviously on a session with a client, but I became more and more aware of my own issues as I met people with similar problems. My last episode of mental illness, what happened was I was suspended from work at that time. My boss thought I'd need to take a rest from work. He wasn't aware that I had a mental illness. So, and then things got gradually worse and worse. I was living with my parents at the time. I remember I was up in my bedroom. My parents thought that I needed to go back into hospital. I was convinced that there was nothing wrong with me. I was perfectly normal. I was off my medication for a couple of months. I knew I had it worked out this time and I wouldn't need to go into hospital again. So again, I didn't have insight. What happened was these 2 doctors arrived at the house, a male and a female doctor. The female doctor actually, she asked my sister, was I aggressive, and my sister said to her, oh, he doesn't have an aggressive bone in his body. So that's not true. I can certainly lose the temper very easily. But this female doctor then came up to the bedroom and said, Brian, I think you need to go into hospital. I said to her, there's nothing wrong with me. I'm fine. I don't need to go into hospital. Despite all the concerns of my family, I had no insight. So she left and I was lying there trying to relax myself in the bed. And the next thing, these 2 burly ambulance men came up to the bedroom and it says, come on, Brian, we're bringing you to that hospital. So these were big fellas and it was a small bedroom. So I says, I better go along with them. So I went with them. They didn't manhandle me, they just brought me into the ambulance, brought me down to the hospital, and I was admitted. I was in the hospital then for about a week, and after a week I began to say, "Jeepers, this is just the same as the last time." As I came down, what would have happened then, I was be put on antipsychotic medication, it would bring me down, and then I would be rational. I said, "It's just the same as the last time." I got that insight, and that was about 2 weeks into the hospitalisation. I was out in 4 weeks, you know, so it was the right thing to do. And I actually think that when people are psychotic, their judgment is wrong. Their judgment isn't there, despite what knowledge they might have of mental illness. And so after 2 weeks, I realised it was the same thing. At that stage, my mood would have been very low, and I'd say, "Here we go again," and I'd really feel bad. You know, that's when the depression, I'd always be on a high going into hospital. The depression would kick in afterwards, the lack of confidence, and I'd feel I'd have to climb up. One of the things I always did after a psychotic episode, I left the job I was working at. And at that time I was working in the Anna Liffey Drug Project in Dublin. I left that job and I started working in probation service and worked there for 18 years. During that time, I would have got married after 1990. I'd have got married at 41 years of age when I got married. I did a master's in equality studies. I did a second master's, and this was in the year 2000 to 2003, in family psychotherapy. And at this stage now, I left probation service in 2009 on the civil service area retirement scheme. And in 2011, I started in my present job, and I work in the Bedford Row Family Project in Limerick. And we work with families affected by imprisonment. You know, even if you're a voluntary patient, there was this talk would happen around the hospital, you know, you can sign yourself out, but it was always a very big deal to sign yourself out. The last 2 hospitalisations where I was committed, they weren't very different from the other ones. And it didn't do me any harm afterwards, you know. No, but I at that time in 1990, we didn't have tribunals like you have now, where a person can come in front. But like, I have a master's in equality studies, so I'm very aware of my civil rights. But there's a time when I'm psychotic that I don't have capacity, and that's the time that I need someone else to take responsibility for me. Knowing that I'm well able to handle my own life afterwards once I'm well again. Even, you know, I'm a great believer in psychotherapy as a way of healing yourself. But while you're psychotic, psychotherapy doesn't work. You have to be brought back to normal, and then you can gain the insight. So I didn't find the 2 compulsory admissions traumatic in any way. They were very similar to the other admissions. And I didn't spend any longer in hospital during the compulsory admissions than I would have spent during the voluntary admissions.
Good evening. My name is Rosie Wilson. I'm 84 years old, and I've been asked to talk about my experiences of the mental health service as a user and as an activist. A bit of background: after studying in Trinity 1956 to 60, I spent 40 years working as a lecturer in London colleges and the Open University, teaching and developing adult learning and access programs for people from educationally disadvantaged backgrounds, members of many different ethnic groups. I was also bringing up our 4 children and helping my mother and stepfather as they grew older. Early 2000, I retired, returned to Ireland, enjoyed doing an MA in Women's Studies at UCD. Late 2001, age 63, I had my first mental health breakdown. My husband and sister were advised to commit me to hospital, where they were told ECT was the best treatment, so they agreed. My memories are quite vague, as ECT wiped my mind. The staff took my clothes, so the first 10 days I was in a night dress and dressing gown. We had to queue up for medication about 10 at night, and a male nurse ensured we took it. I was taken for ECT. I had no idea what it was. No one explained. 2 male nurses secured me on the trolley. I had 8 sessions. After one of them, I fell and broke my nose. After 1 month, I came home. Later, I wrote this poem, ECT. And this, men in white coats bend over her trolley. Are your teeth false or all your own? They're mostly crowned, she says. Her only memory of a month in there, 8 sessions under anaesthetic, a section patient. Believe us, you were very ill. Electric currents have switched your brain towards normal. Take your pills, come to the clinic. But she needs to scrape up snatches of events, half-remembered words like helicopter, dehydration. Her sister shows her a photo taken in hospital after she fell and her nose was broken. 2 black eyes stare from hollows. When she wakes up, she can no longer reach underground caverns where fears and dreams linger among stalagmites, stalactites. Currents wash them away, along with months of memories, leaving a cavity she may not peer into nor fall down there again. The whole experience was very frightening. I was a member of the North Wicklow Amnesty Group, so active in the Amnesty Ireland mental health campaign between 2004 and 2014, looking for reform of legislation, a human rights-centred one, to replace the Lunacy Act of 1870. I was a member of the Amnesty Citizens Jury, where 15 people shared their mental health experiences, nearly all negative, and learned about United Nations Convention of Human Rights for People with Disability, which Ireland had signed up to, but couldn't ratify until reform took place. Hopefully, a Capacity Act will finally be commenced this year, respecting our legal capacity, which is everyone's human right, and our wishes for treatment expressed in an AHD for times our mental capacity is impaired. I continue to be active for mental health reform with the Coalition of Galway University, Recovery Experts by Experience, Mental Health Reform and other groups. In 2007, I was a voluntary patient in the same hospital, where the Mental Health Commission reported 88% of us were over-medicated. In August 2017, I had a very serious breakdown and was voluntarily admitted to another hospital, deep depression with psychotic symptoms. I was convinced I was the most evil person in the world. I'd used up all the fresh water in the world. I'd murdered 3 close family members. I was killing my roommates, using up all the oxygen. I'd ruined my 4 children, all out on the streets. In short, I was in hell. After trying all other ways, my consultant agreed with my children that I should have ECT. I refused after my previous experience. It went to tribunal. I was made an involuntary patient for 11 sessions, agreed to a final treatment. Nurses were very kind. I don't know how they put up with me at all. Continuing aftercare by old age psychiatry, consultant and nurses is excellent, restorative and supportive. We meet as equals in my own home. I gave my GP and community consultant copies of my Advanced Health Directive, which they have put on file. The consultant invited me to a training morning in the hospital. The 2 of us had a 45-minute question and answer in a group of 30 psychiatric staff who were genuinely interested. Mine was the first Advanced Health Directive they'd seen, and they were positive in their response. What doctor would not want to know the care wishes of patients?
Some very powerful testimony there from Rosie Wilson and Brian McNulty. Thank you both very much for sharing your stories with us. I'm going to go to the panel now and ask for your thoughts on those stories and what your take home would be from that. So first I'm going to go to you, John.
Yeah, I mean, first of all, I've worked in psychiatric hospitals for many years, and I mean, it's even when you work and you're caring for someone and you're trying to help someone, when you hear that person's, you don't sometimes get to hear the perspective when you're in the hospital. I know that sounds strange because you're all the time working, medication, ward rounds, etc. And it's something that's stuck in my mind that when I'm listening to that is, like, we need to make sure we have the right amount of people to listen, to work, to spend time, to I'd rather have spent 4 hours in the bedroom than the 2 burly ambulance men. Let's put it that way. Do we have time and do we have the training? But just to hear, what I love is that we have people who are wise, have experience that I don't have, and just that we use it and we listen to it. I was really interested in the difference, not really seeing any difference when you're unwell in terms of the psychosis, because between the voluntary and the involuntary. And I often remember speaking to people who've recovered from psychosis, because we set up a first counselling service for people with psychosis in Ireland about 25 years ago, and people speaking about they don't kind of remember a lot. But when you're working with someone, you just, I don't think you really get that until you experience it, or someone says it like you said it, like the 2 people there tonight. So just thank you. That's all I have to say.
Thank you, John. Bert, I'll come to you for your thoughts next. I know Rosie's video in particular, she had some harrowing experiences there.
Yeah, I've been privileged enough to hear from Rosie a number of times. I've been with Mental Health Reform for a year now, and she's an absolutely remarkable woman. And Brian, I think for me, the thing of hearing the 2 stories shows how individual mental health difficulties are and how people don't fit neatly into any sort of boxes, and that no 2 experiences are the same. And that's something that I'm hoping we'll talk a bit more about tonight. But I think Rosie and Brian both touched on their opinions of, you know, the treatments that they got and how they felt about things. And it was interesting to see even the language and that they used, and talking about involuntary and, you know, being voluntary and then having some involuntary treatments, you know, so that's a conversation as well. But I think it's really with the amount of stigma and discrimination that's still around about enduring mental health difficulties, I think it's really, really brave and commendable to speak publicly about your personal experiences. And I think it's so important because we can talk about the statistics, but it's the people at the centre, it's the person, it's their family, friends, carers and supporters, it's the community, and it's the effect that it's having on them. So yeah, I'm really just, I'm always grateful to hear from people. People shouldn't have to tell their personal stories, they shouldn't have to re-traumatise or upset themselves or share these, you know, their secrets or their personal moments or personal health moments, but it really is powerful to hear the voice of the people. So
thank you. And June, yes, as a medical journalist like myself, these are very important stories and ones that we don't hear enough of. What were your thoughts, I suppose, really on the key take-home points from both of them?
Yeah, again, I mean, both Rosie and Brian to be commended for sharing their stories so well, so clear, so impactful. What I saw from those 2 videos were 2 highly intelligent people. They had masters coming out their ears, jobs in really important areas, you know, just 2 highly bright, intelligent people. And it just shows you the importance of recovery, because you can get very, very unwell, but you can also recover with the right treatment. And when you get the right recovery, right treatment, you go on to get your masters, you go on to do incredible work. Because we tend to dismiss people with severe enduring illnesses as, oh, they'll never get better. But when you've got amazing testimony and real life personal stories from people like Brian and Rosie, it just shows you that actually you do get better, you can regain your life, and you can go on to do some more amazing things. So I just saw 2 highly intelligent people, like, blowing me away with their experiences, and they're to be both commended.
Thank you, I very much agree there. And Lurkin, as a psychiatrist yourself, you see cases like Rosie and Brian all the time, but we don't hear, as I suppose, about their cases really that much in the public. What were your thoughts really, I suppose, from their experiences?
At the outset, what I would like to say is, you know, when people think of mental health services, they tend to think of mental health hospitals. And one of the things is they very often think of the sort of experience that Rosie had in her first episode. And most people who attend mental health services, the vast majority actually never go near a hospital. I suppose that's the first thing we should say. And of those who are admitted, an even smaller fraction are involuntarily admitted. For those particular people who are particularly vulnerable and particularly ill, I think we need to be very mindful of what that experience is like for them. Both Brian and Rosie presented very different pictures, but Rosie even presented very different pictures between her first episode and her second. And I think one of the things that struck me from Brian's was when he spoke about the lack of insight And when we say that, what we mean is that people lose the understanding that they are unwell and that they need treatment. And as Brian very, eloquently put, once he started to improve, that came back. And I suppose from Rosie's perspective, it shows the difference between when she was put at the centre of care. Because in her second episode, she said the nurses were kind, they listened to her, she became part of that conversation, she became part of her own recovery. And that is really important as mental health professionals, that we never lose sight of someone's recovery. Our aim is obviously to provide the best possible treatment in the fastest possible way, but also to help the individual get back to being the best they possibly can. And as Burr mentioned, and then June mentioned, these are illnesses that don't just affect one individual. They affect the person themselves, obviously, but they've got families, they've got friends, they've got jobs, and it's really important that as mental health professionals, we do everything possible to support them in getting back to their loved ones, in getting back to their jobs and back to their lives. And it's interesting when Brian said he got married at the age of 41, and that was already after a number of episodes of illness. So people sometimes say to me, oh my God, my son has schizophrenia or bipolar disorder, can he have a life, can he get married? And the answer is absolutely, with the appropriate treatment and supports, people can have fulfilled, happy lives. But we need to be careful that, we put them at the centre of our care. And then obviously when, we do need to get to the point where it's last resort in voluntary admission, that all the appropriate precautions are put in place, that their wishes are taken into account, that if they have advanced healthcare directives, we listen to it, and, really put the person at the centre of what we're doing.
Okay, thank you. And Frank, over to you. As an authorised officer, obviously you have experience of a lot of similar cases too. And what did you think, I suppose, really from their videos there?
Yeah, I thought, particularly listening to Brian, I thought his story was an amazing story. It was ultimately an amazing story of hope. Sometimes it's uncool. Nowadays people think insight. We don't like this term insight. It's rubbish. What is insight? What isn't insight? But I was on a mental health training course, and we had this fantastic advocate who was a service user by experience. And one of the questions I asked him, do you know when you're getting on well, I'm an authorised officer. The reason why I want to be an authorised officer is I want to be able to ensure that someone like Brian, who doesn't have a loving, caring family, can have somebody to meet him, and if necessary, if he is so unwell and has lost insight, that I'll help that involuntary admission if it's necessary. But this trainer said to me, Frank, you know something? You have some hope in the first couple of weeks and when I get well of persuading me to come to hospital. But if I'm left untreated, I am so locked in my own world, there's no way I'm going to agree. So one of the nice things of Brian's story is that he had a loving family. He also offered hope. If you take treatment that's recommended and you're happy to take it, you can rebuild your life. The stigma is beginning to fade, and the expert review group talks about dignity. If you remain untreated in hospital for too long, you lose your dignity. Day in, day out. I was involved in an involuntary admission this week, and this poor woman, I don't be patronising, but her house was a mess. She took refuge in her brother's house. Her brother called the police. Myself and a GP were trying to assess her under the Act. She was saying rude, obnoxious things to her loving brother, who she loves. The reason there is she never really gained her insight into her mental health, and she lives alone. She doesn't have loving family members, and as a health service, we're trying to get people their own homes and own houses. But the challenge to that, because I worked in England for years, you'd have people with severe enduring mental illness living on the 14th floor of a tower block. We as a mental health service had to prioritise those patients because there weren't family members to do what I think Brian's parents did. The great hope here is Brian got back working and became a social worker like myself. Brian got married, as Lorcan has said. The challenge for us is, and that was under the old Mental Health Act where there isn't tribunals, 2001 has tribunals. The challenge for us is that the expert review group, they want to change the involuntary admission criteria. As it stands, I think Brian was admitted on the health ground. Brian, if he didn't get treated, it might lead to a serious deterioration in his condition. It might, but the new criteria is that there's an imminent threat to the health of Brian. So the reality is, if our Mental Health Act changes, Brian would probably not fulfil the criteria for involuntary admission, and Brian would be left at home unwell for a longer period of time. What actually happens is that the parents eventually tell Brian to get out of the house. Social workers call and say, we're going to get you a barring order. Brian would end up perhaps in homeless services. So the important thing is that we get the balance right. Brian lost his ability to judge situations and he regained it. So it's our priority as in the public mental health services is those families that don't have family and relatives. So I do think there is so much in that video, and Brian's story is so important, even though it's a little bit out of date. Day in, day out, 90% of the people I'm involved with in the assessment under the Mental Health Act, they're not articulate. They could not come to this meeting and tell their stories, but their stories are similar. And some of the patients I work with never regain insight. They have delusional thoughts all the time. And the last point I made, if we change the involuntary criteria, we have to discharge people off the involuntary admission order, perhaps after 2 or 3 weeks. And we know with the revolving door patients, they're not there yet. The woman I mentioned earlier who I was involved in her involuntary detention was only discharged 4 weeks earlier, and she was as unwell 4 weeks later as she was when she was admitted.
Thank you, Frank. And finally, Kate, coming to you, just for your thoughts on the video, and obviously with your background with the guards, they're actually involved in a lot of involuntary detentions in Ireland, and there's a lot of legislation there, there's a lot of training, and I suppose, how do they deal with patients like this?
There is. Just before we move to my day job role, I really want to say that on a personal level, unfortunately, due to an IT glitch, I wasn't able to preview, so I was watching both Rosie's story and Brian's story for the first time. And just on a very personal level, the value educationally for having the story told in such an articulate, concise and compelling way would be the type of training we're attempting to do with An Garda Síochána. And I've certainly spoken to the president, to Dr. Flannery, to involve personnel on today's panel and yourselves in our ongoing training, because I think there is the rawness of the personal experience that speaks to everyone's understanding of the complexity of life. But also, I saw it as a great story of hope. I absolutely agree with Frank, because 18 years in the probation service without any other challenges is some legacy. And Rosie's story of access education, in fact, mirrored my own and was her pre-retirement life, but her post-retirement life, again, mirrored my own, which is very much being a retrofitted human rights lawyer. So all of us, old as I am, did not have compulsory human rights training because there were no Human Rights Acts in either jurisdiction I've worked in or practiced in. And I do think that Rosie particularly honed in on the advances. If you looked at the change from her earlier experience and the complete, I suppose, reversal of involving people in decisions at a time that they are in a position to contribute to. And Brian, you made that point very well. You said at points someone else has to take responsibility. I thought that was, for me, the most powerful, insightful line for what informs An Garda Síochána at Section 12 is the part of the Mental Health Act that An Garda Síochána encounter between 5,000 and 6,500 people a year, not in involuntary admissions, but in calls for assessments. And it is my absolute desire to ensure that we are equipping An Garda Síochána, who are generalists. It has to be remembered, a force of 15,000 cannot all be specialists in all areas of the law they practice in. But the huge improvements are, in my view, that policing, the professionalism of policing, has made a huge leap forward in the accreditation of a Bachelor's of Policing under UL, so a professional policing qualification that is augmented most recently with us, with human rights training again to level 8 accreditation by UL. And that is the I think, the place to bring this expertise in, so that you are speaking to the frontline service providers. Although neither yourself nor Rosie had an interaction with An Garda Síochána, I'm going to take the two Burley ambulance men as being analogous to the type of Burley guards that I work with on a daily basis. So really it's an invitation to bring that expertise in, but also to acknowledge the enormous work that has been done. A recommendation of the Commission on the Future of Policing said that the core function of An Garda Síochána is keeping people safe. And I would say, Brian, you gave me the line, keeping people safe at a time for that period where they are not able to keep themselves safe is, I think, the core value of what Section 12s are about.
Thanks very much, Kate. And last but not least, to our final panelist, Dr. Anne-Marie Naughton. What were your thoughts really on the video testimonies we just heard?
Thanks very much. And again, you know, those were really powerful testimonies. And I think any of us who are particularly in general practice or psychiatry, we really have to be interested in people and people's stories. And it's very patient or person centered. And it's, as has already been mentioned, to have such articulate descriptions of interactions with the mental health services. And I suppose what's also important is that lifetime trajectory of the illness. So, you know, so you can see that this is not just one episode. So these are that episodes happen over the course of recovery and relapse. And I think what's really important for me is if we look at kind of chronic mental illness or severe mental illness, you look at it as a chronic disease. And if you look at the people who spoke, like Brian and Rosie, there's that whole idea that there's the ongoing link with the services. So their mental health team, presume their GP, you know, the nurses that Rosie spoke about at the end. And I think that as a GP, you know, we see people before they become unwell, when they are unwell, when they come back out, and there are psychiatric colleagues look after them in the community and in the hospitals. And I think that that's one of the really important things is in terms of trying to keep people well. And as Frank spoke about as well, you know, with the patient he had, trying to recognize that earlier deterioration, which you will see when you've built up this relationship with people. And I think as well, you know, it's fair to say, if you think you'd look at Brian's testimony, that when his family were very concerned about him, he felt he didn't need his medication, he'd come off his medication. And I think if you think about him being in his room and that doctor coming and you know, to see him, or the two doctors to assess him, and I think a lot of steps were taken to sort of avoid going down the route of an involuntary admission. But it just transpired that, as as Brian himself said, he didn't have the insight. And it was the way that he went in. The two Burley ambulance men brought him to the hospital, but where he recovered quite quickly and was, you know, regained his insight and has gone on to have, as he described, a really interesting and varied career with huge contributions to society. And I think that it's important to recognize that this is usually a last step in the community. None of us want to go down that route of sending on someone into hospital or recommending they be kept against their will. But in cases, it is where you are providing somebody with the right to appropriate treatment, and you allow them to reduce their period of untreated psychosis or untreated illness. And then you're allowing them an opportunity to be afforded the treatment and to get better faster. So, you know, I suppose from my point of view, you know, looking at the Act, and I suppose I've been involved in an awful lot of this process. And I think as well, it's important to recognize that when you're looking at somebody with the severity of their illness, disability or dementia, the judgment is so impaired that the failure to admit them would be likely to lead to a serious deterioration in their condition. But also, there has to be likely to be of benefit or alleviate the condition of the person to a material extent. And I think that's fair to say that the stories that we have heard have shown that to be the case. And I think then, you know, Frank touched on those cases where maybe they don't get the intervention that they require and they have a prolonged untreated psychosis, and the behavior and the illness deteriorates until the point where people maybe have a barring order or asked to leave the house. And I suppose where I work in homeless services, that is where some of our patients come from, you know. So I suppose we see the most downstream versions of where the earlier intervention didn't happen. And I suppose what's really important to me, I think, from the two stories that we've heard is we can always improve, you know, that there are always ways that the system can be improved. and the way we do things can be improved. And I think it's fantastic to hear Rosie talk about, coming into the hospital, speaking with her consultant and telling her story to the psychiatric professionals that will be helping her and working with her. And I think we all like to hear the stories and the feedback, and it's really important that we are listening, and it's a partnership approach with the people we're working with. But as Brian said, when he's very unwell and when he lacks insight, he is not at that point able to access the treatment he needs to become well. And I think, we have to have the courage and we have to take the responsibility. And it is a difficult decision. Anytime I'm involved in any of these processes, I certainly lose sleep. There's a lot that is done to try and avoid getting to this point. But I would always hope that somebody would have the courage, if it was me or my family member, to allow me to access the treatment and the care that I needed to become as well and articulate and able as the two people that we have heard tonight.
Thanks very much. I think you've outlined very well just, I suppose, how things work currently under the legislation, how you deal with patients. And I particularly liked your point about how you can see patients before they become unwell, during and afterwards, and the recovery period. So I think that's something as well that the other panel members have touched on, their own experiences currently under the panel. Bert, I think you want to come back in there.
I did, Priscilla. And sorry, this is probably where Andrea will not invite me to speak at anything, and Niamh is cringing, so apologies, but I can't let Frank's comments go unchallenged about the new Mental Health Act. And he used Brian's really brave story and Brian's own words to paint a picture of conjecture of what might happen in a scenario with a new improved human rights UNCRPD compliant legislation that is needed and has been needed for years. So I think there's something like nearly 200 people registered listening today, hopefully a lot of psychiatrists and people working in the area. And I want to give the message I would be doing an injustice to our 81 member organisations who work across the community and voluntary sector, all of the many thousands of people that they work with, all of the people who share their lived experience with us. If I didn't challenge Frank's comments about the reform of the Mental Health Act and the long-awaited and much-needed changes that are coming. There's a lot of, and I know we're going to be talking about the new the reform that's coming, and there's just a couple of other things. So the points as well about revolving door patients and the woman who was unwell 4 weeks later, to me, that's just the best example of why things need to change, because they're clearly not working for people who really, really need the services. And in our own research previously in 2019, we did My Voice Matters. It was one of the largest research pieces of people accessing mental health services, and then also their family, friends, carers and supporters. And that showed that there was a huge over-reliance on medication, the biomedical model, people not being listened to and not included in their care plans. So, they're all things of listening to people and their experiences that's really important. But at this point, I also want to make the point of it. We all said how articulate Brian and Rosie are and sharing their stories, but I think we have to be really careful to not create kind of a two-tier, palatable person accessing services, so the ones with the masters and the jobs and the loving families, and then the ones who couldn't necessarily talk about their insight or their experiences. At the end of the day, they're human rights. We're all human. Any of us could need to access them at any time. And if we have our advanced healthcare directives respected, that's something we can talk about again. But I just some of that again, if people are listening, anyone, half of us can have an experience with a mental health difficulty at any one time or been impacted at various levels. So they're just some things that I just want us to keep in mind.
Thanks, Bert. And actually, that was a very important point that was put out this week by the Subcommittee on Mental Health. Their pre-legislative scrutiny report on the draft heads of bill to amend the Mental Health Act. Bit of a mouthful there, but the key recommendation was that they wanted a stronger focus needs to be put on a human rights-based approach within the proposed legislation, as you've just pointed out there, and that the proposed heads need to fully adhere to the UN Convention of the Rights of People with Disabilities. But I suppose the current legislation, it's 20 years old, it's 2001, but it was a huge improvement on what came before, an incredibly outdated piece of legislation. And the Mental Health Commission was put in place not just to inspect services, John, I'm going to come to you, but also to protect the rights of patients. So obviously you have that experience there. Just it's not just about seeing that there's physical buildings in place, but that the rights of patients are protected. Are they under the current legislation?
Well, you see, it's the 1945 Act, then the 201 Act, and then this Act. There is no doubt that there's incremental improvement as you go across it. I remember the 1945 bringing in the debates around the 201 Act and people saying if it came in, God, it would never work and people would be unsafe. I remember all that. Because change, these are big changes. Mental health, it would be much better if we were doing things incrementally. But I suppose there's a couple of points I want to come back to. Number one, the Mental Health Commission is dependent on mental health professionals throughout Ireland to make sure that rights are vindicated. So that we have our panels of psychiatrists, of barristers and lay people who absolutely make sure that the law is put in place properly and that the clinical aspect is right. So there's a lot of challenge there as it is, peer review, challenge. And I just want to get across to people, and it's really important for me, particularly people for members of the public, there is a cohort of people in Ireland who, when you become mentally ill, it's very different to what you might hear about, mental health or having your worst day or whatever. And in fairness, our contributors tonight gave us a kind of a sense of that. So it is not easy to provide compassionate, caring, individualised patient care for those people. And it is most definitely not easy when we don't have the buildings in place. So involuntary detention, as far as I'm concerned, if you're depriving any individual in this country of their liberty without their permission, either way, if they have an illness, whatever, it must at least be into the most dignified premises you can find in the country, not into some of the premises that I'm seeing people put into in this day and age. There is no way the best professional in the world would find it challenging to work in some of those buildings, and there's a few of them. And then I see the other buildings where they're much better. The second thing then is that, it's like a domino effect. You're not going to attract quality staff into a service that isn't set up right. So if you have a high quality building attached to an academic institution where there's a praxis of learning, this is where we're trying to compete with in other countries. So I do think, like I was given the example when you mentioned about the Burley ambulance men, because I would rather spend, you see, the people that were described here in different things, and Frank, some of your opinions, I've helped those people come into hospital voluntarily. People with psychosis, but it takes time. It takes a really strong relationship. It takes a huge team of, psychiatrists, social workers, a really, really big team. And I know from regulating the services now that there's very few teams with the right amount of people in them. But where there is, we're definitely very good. And I just want to really get the message out there that in regulating the system, we regulate the mental health system robustly in Ireland. The state does that. Everyone cooperates with it. In general, we have a quite a good system that a light is shone on, much more than any other system. So I just want to really get across to people that Ireland as a country, definitely we do absolutely our best, but we now have to move. We're now required vis-a-vis international law, research, evidence, to move to a different space. But that's going to take absolutely take time. And I'm very interested in listening to the points around the Act, the technical thing about the Act and involuntary detentions. Because for me, we might, whatever we decide on, we have to make sure we have the staff, the community services and the dignity for people so that you can actually have a relationship with someone. When you mentioned your story for 18 years being in a place, I mean, that to me is important because sometimes, and I don't know if people, other professionals find this, but when you have a doctor or a nurse or a social worker or psychologist who's in a place for a long time, you build up the trust. There is a trusting there where you don't have the staff and the movement. It's hard. But I just want to really send out that message that I do think we do a good job. And just looking at our stats, we've low detention, involuntary detention rates in Ireland. We have a compassionate regime. I personally trained in the medical model where I see people, I saw young men come into my unit who were so distressed, their mothers were so distressed, they thought their life was destroyed, and with the right treatment, they recovered, you know. So, but for me, I wonder now, because what's happening now, I'd be more concerned about the first-time admissions, the early intervention, and we might talk about that. But overall, I think looking as a mental health commission, I do worry that we don't take psychiatry and intense illness and psychiatric illness as serious as we do, for example, other medical illnesses like cancer, etc. I do worry about that.
And I'm going to come to you now, obviously, because you're working in the system, and I suppose for some people listening at home, there is a lot of strict criteria to admit someone involuntarily, and just even they have mental health tribunals to review their case, but that doesn't mean that things can't be improved and that a human rights-based approach can be integrated better.
I suppose, I mean, there's always room for improvement no matter what you're doing. And I just want to come back to something Burr said earlier on, you know, about the person being involved in their care plan. That's a very important part of what we do already. And in fact, we're mandated to do it by the Commission. And what John said about, you know, having the best possible environment to admit somebody into, whether they're voluntary, involuntary, or whatever. But when we talk about human rights, I think we also have to talk about the right to treatment. And there is a very small number of people, and as John said, you know, these are a very small number of people who are seriously ill, who need treatment, and very often may not realise they need that treatment. One of the difficulties is that serious mental illness, and again we're talking about a very small number of people, serious mental illness should be treated quickly and effectively. If it's not, and Anne-Marie touched on it earlier on, that the longer you let it go on, the longer it takes to recover from it, and the less likely it is that you will get back to where you were before. And that's something that's really important. So I mentioned earlier on about getting the best possible treatment to which everyone is entitled to, no matter what area of medicine you're in, but also as quickly and efficiently as possible in the most compassionate way. And absolutely we should have well-resourced facilities, be they inpatient or outpatient. Certainly I know from experience and working with a well-resourced community mental health team, what John says is absolutely correct. You are able to work with people, you develop relationships. But there is always a small core number of people who will require involuntary admission. And they mightn't necessarily be people who are in immediate or serious risk of harm to themselves. In fact, most people that I would be aware of and would have come across who are admitted involuntarily don't fit that criterion. And they're people who would, if not admitted, languish in the community in mental illness, losing jobs, socially embarrassing themselves, losing relationships, making unwise financial decisions. And of course you can argue, well, that is their right. But at the same time, if their judgment was not impaired, would they make these decisions? And these are the group of people that I feel will fall between the cracks if we don't have the facility to admit them. So if we're reduced to only being able to admit those who are a serious risk of harm to self or others, then we're going to have a very small cohort of people, but there are going to be people, and absolutely it's a small number, but they will be people who will fall through the cracks, who will either languish in the community, wind up in the prisons, wind up in the A&E, wind up homeless, or wind up in psychiatric hospitals where you can't treat them, and then they sit there for months on end, which brings us right the way back to the old institution where somebody went in and never came out. So I do think the concept of the right to treatment is really important. However, and I mean, I am coming back to incorporating people's will and preference as much as you can. It really is important. The person must be the centre of it at all times. And that really is important. And it's a discussion. I mean, obviously, when someone presents to you for the very first time and they're psychotic, you don't have the opportunity to have that discussion in a meaningful way. But as soon as they're well, that's when that discussion starts. That's when you start to engage with them in a partnership that is potentially lifelong, depending on the illness. And you build it up over time, and you get to know each other, and you get to trust each other. But I really do think that we shouldn't throw the baby out with the bathwater, and we need to remember that there may be a group of people who will wind up untreated if we're not careful.
Okay, You know, that is a very relevant point, and I think that's at the crux, isn't it, of the current legislation and the proposed legislation. How do you protect people, but how do you respect their human rights at the same time? And that is a kind of an argument overall in medicine that's changed a lot in 50 years. We're moving much more towards shared decision making, patients having, you know, a lot more input into how they choose to be treated themselves. But as you've pointed out, in emergency situations here, and I suppose just a few statistics really, I suppose there's about 15,500 admissions to inpatient psychiatric units every year, isn't that right? And roughly about 2,500 to 3,500 can be involuntary. Obviously that can change during the duration of the stay. So again, yeah, they're a small number, but a very important number, obviously. And I think, June, coming to you as well, part of the issue really, I suppose, out there is that patients and people in the public, they might know a lot about the legislation. They might know a lot about what happens if you do have an acute mental health crisis, because what we see on television a lot of the time is physical ailments, you know, how they present, how you're treated, but there is still a lot of mystery there. And I think, should we try and increase the amount of discussion that we have in public about this across the media?
Yeah, I think you're right, Priscilla. I mean, there's still huge stigma surrounding severe and enduring mental illness. We're all getting much better speaking about depression and anxiety. And that said, depression and anxiety can be severe and enduring as well. But we're getting much more comfortable talking about it. But we have a long way to go before we talk openly and honestly about things like psychosis, schizophrenia, all these very serious mental health conditions. And we don't talk about them. There's a stigma attached to them, and therefore they're frightening. So if we don't talk about them, the less we talk about them, the more frightening they become. So the more we have open and honest discussions, the more we use everyday language to explain to people, this is what happens, and you know, you will be at the centre of your care. This legislation is there for you. But the legislation, I mean, looking at over the reports over the last couple of weeks, it's all written in a language that's confusing. It's not easy to read for the general public. It's just legalese, boring. You wouldn't get past the first couple of paragraphs. So if we want to engage people, we need to use a language that speaks to them and informs them of their rights, which are so important, but also reassure them that when you get really unwell, when you need that help, it will be there, and it's your right to access it. And then when you get that help, you can come out and you can get back to your full life again, if that's your choice. I mean, that's an ideal world. I know there's lots of situations, unfortunately, where people don't have family, or they're dealing with a dual diagnosis. They've got an addiction problem as well as a mental health condition. So there are challenges, even more complex cases, but we just need to speak about it more. We need to go down the road of the serious and severe enduring mental illness and remove their fear, but also reassure the public that they will be looked after and cared for.
Okay, so I think that's a very relevant point, that we do have a wider discussion about the current legislation, the proposed legislation, because as we know, major changes in society and legislation happen when the public get on board, when the public want things to change. We've seen that with divorce, with termination of pregnancy, etc. So really we do need to kind of broaden, not from well beyond, I suppose, people who work in the services and patients who are directly affected by this as well.
Exactly, and all those really important campaigns, if you think about them, like, you know, the marriage referendum and the abortion referendum, the movement came from real life stories. That's what people remember in their heads. So that's where people like real life lived experiences are really powerful. And we can, but it's not an easy thing to tell your story. You're reliving this trauma, which is a hugely traumatic experience, but we can support people to tell their stories and be there for them afterwards with that impact. So a real life story is so impactful.
Very much so, and certainly from our videos tonight. And also, I suppose, for people to know who's in charge of what. Kate, just in relation to the guards, and Frank as well, for authorised officers. I do know of case of someone who was involuntarily detained a number of times. There was a doctor involved once, but the guards were involved a couple of times. And actually, on another occasion, when they became very unwell and they could sense they still had some insight, they went to the guards for help, because they knew that the guards could get them to hospital and get them in. A lot of the public, they mightn't even realise, you know, that the legislation is in place there and what the guards can do to support someone at an extreme end of a crisis, and we know that they're very involved there. So,
and you know, it's interesting that a number of the speakers have highlighted concerns that we in An Garda Síochána would share about the physical environment. On the negative side, a custody suite is not the place to hold anybody who's unwell. However, on the positive side, many community guards and guards throughout the country have very strong local community ties. They understand and have good relationships with the vulnerable, a broad term in their community, and they are often the first port of call from those persons as well. It works both ways, but that doesn't change the fact that as an environment, the criminal justice system and its buildings are not appropriate venues. So I suppose the promise of the development of co-working in far more bespoke and designed bases, this panel will be well aware, and probably many of the listeners, of the pilot scheme in Limerick, which is promising. It's in the earlier stages and is likely to lead to the pre-pilot. I'd never understood such a term before, but there's a pre-pilot in formation, because I think there's acceptance. A pre-pilot tells you everyone accepts there's a lot yet to learn. Authorised officers would be welcomed by An Garda Síochána, and Garda Síochána gave feedback on the heads of bill because of the numbers involved and the geographic spread. The reality, however, is in a community of our relatively modest population, spread as we are, our demographics are against us, and you need to have emergency responders trained appropriately in human rights approach, so that the least intrusive approach, the most, I suppose, trusting approach is developed by those who invariably are going to be those first-time responders for many. But there are huge opportunities. If you look at the public attitude survey, we in An Garda Síochána have one of the highest trust levels of any policing service anywhere in the world. It's up in the 80s. Who would you turn to? So I'm not suggesting that makes it the right place to bring people, but at least it is a building block that we can modify. And the modification's got to be bringing people in a vulnerable state for assessment to an appropriate venue, in my view, and the Commissioner's view.
So just to remind those listening at home, the proposed legislation wants just authorised officers to be able to detain people under the legislation, whereas currently other healthcare professionals are involved, GPs, the guards, and obviously, Frank, you're an authorised officer. There's certainly nowhere near enough with your skills and qualifications to undertake this task.
I mean, as Lorcan will say, I mean, the applicant literally signs a form. My job as an authorised officer under the Mental Health Act, and I'd probably disagree with June, I actually think the 2001 Act is the most readable piece of legislation you'll come across. There's a few little things that are going to be changed in the new Act. The timing. So if a GP sees a patient and thinks, oh my goodness, they're really unwell, there's no family member willing to make the application, I need an authorised officer. The team, obviously, if they don't know the patient, that's fair enough. I go with the GP, or I go on my own. I go on my own. I think I agree with you, Dr. Murphy, this person needs to be involuntarily detained. But actually, the Act says you have to see them again, because I make my application before you, as opposed to you doing it and then I do it. So that was a bit of a cock-up in the Act. That's been resolved. So there are lots of good things in the Act. I mean, just before I get to the authorised officer piece, I think everybody in this room shares the same principles and values. Patients' rights must be respected. We should always try to intervene in the least restrictive way. And that's because I was involved in the very beginning when the authorised officer was put in place. And the reasons, because the policy is way ahead of the Act. The policy says, look, we want the authorised officers to be mental health professionals. The Act kind of hinted they couldn't be. They can't be staff of the approved centre. We got around that. We want you to look for the least restrictive alternative. As a social worker, I'd be the first to say, yes, that's great. When I was doing the applications for involuntary admission, I was so proud of myself. You know, I avoided the admission of patients. But the question some of my colleagues said, well, what were the outcomes? Did that person remain well? What happened later on? On some occasions, the family may sign the form the following week because they were so terrified of the relative. But when I met them, I thought I was doing a great job. So I think it's about ensuring that our service users have a good quality of life, but that we avoid relapse and readmission. We don't actually have community treatment orders in Ireland. I used to be at the equivalent in the United Kingdom. They have community treatment orders. What does that mean? a moment ago you said there's about 2,000 people involuntarily detained. It's less than that in the community. What happens is some patients go voluntarily, they're really unwell and they want to leave. And the nurses see, my goodness, if he leaves, he's going to be very, very vulnerable. So sometimes it's a holding power process. There's some people, again, who are so unwell, we use what's called the Hogan ruling. They're sitting in a room, they're not eating or drinking, and we didn't know how to treat these people because the Act said they have to want to leave. And of course, an authorised officer can make an application like as if they're at home. But the point that people need to know at home is that those 2,000 people who are involuntarily detained, many are detained 2 or 3 times in the 1 year. And that's the bit that's missed. My colleagues who do what I do in the United Kingdom says, we never do revolving door patients, because if they've had 3 or 4 involuntary admissions within 1 year, they're placed on a community treatment order. All that means is when they stop taking treatment, like Brian, 2 or 3 weeks, they're showing they're becoming unwell, they are brought to hospital and they are told, will you take your medication or we will assess you under the Act. That allows the equivalent to what I do, providing this 24/7 service. In the United Kingdom, their job description is, if you're going to be a mental health social worker, you must become the equivalent of a HSE Mental Health Act authorised officer, or else you ain't going to have the job. When we started off, my own professional body and some of my nursing colleagues, we had to almost go against the unions because the union says, no, this is a terrible, there's no salary increase, you're doing it as your day job, you get a payment for doing the assessment. Some patients I have tried to visit 6 times. I've climbed over balconies, I've knocked on doors. I've got GPs to come out with me 9 in the morning. I've got GPs to come out with me 8 in the evening. And finally, that patient goes into hospital, they get well. I take issue with Burr because there is a significant difference in the change. As Lorcan said, the health ground is a significant reason for people to be involuntarily detained. The change to the criteria will say their health is at imminent threat to their health of the person if they are not brought into hospital. The health ground before used to be, if they're not brought into hospital against their will, it could lead to a serious deterioration in their condition. It's hugely different. And the reasons why it's different is because the Act is suggesting that the minute that threshold is not reached, no consultant can keep that person on a detention order. We all know who work in mental health services. I worked with a patient recently. He hadn't been treated for 2 or 3 years. He was in hospital, again, previous to that. He said, look, I want to go home. I'll take my meds. I'll call to my appointments. He didn't. He was a slow deteriorating patient. And again, he wouldn't open the door. The family were distressed. I assessed him under the Act and thought he was a lovely young man. He said he was fine. The family were distraught. And again, it was only when he did criminal damage to a neighbour. He was convinced this neighbour was an undercover police officer. He broke security cameras where he was living. Only then he came into hospital. Again, a new consultant involved in the case. He's saying, look, this guy seems to be making great progress. And it's only when he was challenged a little bit, it was clear he had no intention of taking treatment. This young man, I won't give his age just to keep the anonymity, he remained in hospital for an additional 2 months. He became terribly upset, very down, because suddenly he began to realise that the neighbour wasn't a secret undercover police officer. Suddenly he was engaging a bit in OT activities. Suddenly he agreed to us manage his finances and we could pay the €800 gas bill he hadn't paid. Suddenly he started talking to his family again. Suddenly he agreed to outpatients, to home care. The man has engaged in services that the change to the involuntary admission would put at risk that he would be discharged, a bit like Brian, who had insight. That's my concern, and with all due respect to Burr, I have worked in the mental health services since 1994, and I've been the equivalent of an authorised officer since 1997. So what is the problem with making the recommendation 36, that all of a sudden the expert review group said it can only be the AO applicant? Nobody proposed that. Absolutely. The steering group interim report said a hierarchy. My professional body said a hierarchy. Try and get the AO first. If you can't get the AO, any other person. The reason why the police are involved is because they're involved in emergency situations. If I'm asked to get involved, I ring up a doctor. Are you free? Yes. When are you free? 5 o'clock today. I go out at 5 o'clock today. There's no answer. The reasons why the police get involved is they get a phone call from a relative. My brother is on the roof, distressed, and he's threatening to harm himself. Or my sister is psychotic, or they seem to be involved with drugs or whatever. The police are the only people that are involved in an emergency situation like that. The same thing happens in Britain. They're brought to a police station or wherever, and then an authorised officer makes the application. All that happens now is the police officer makes the application once they're sure there's a bed. And the problem with suddenly saying, let's have a full AO service, my area is one of the few places we have 3-day training, which is pretty limited. We have a peer support, group supervision, we support each other. There's 4 AOs for the catchment area I work in, which is a big catchment area. There's 4 in a neighbouring catchment area. A lot of the AOs have been trained, have just said, I ain't doing it anymore. My understanding is there's no active AOs in Cork and parts of the country. So it's not because the psychiatrists are bad and evil people that they're saying the idea of making it AO only is daft. The subcommittee, in fairness to them, of saying, stop the lights, introduce the Act, but gradually increase the AO, the number of people who are HSE AOs. And remember, it's a voluntary thing. It's not part of our contracts. So how are you going to persuade people to work 24/7 on call? It will take time. I'm not saying it's a bad idea, but it will take time.
You said it was a daft idea.
Yeah. Well, I suppose you've pointed out that it's something that's very easy to write down on paper, but that the reality is incredibly complex and intense. And John, what are your thoughts?
I'd speak to about the AOs. So a lot of people want the AOs. The AOs in the Act, think about it this way. A lot of families in the research don't like to have to sign their loved ones into hospital because they feel it hangs on them for a long time. In terms of the guards, we were spotting that over COVID, that it went up by hundreds of percent, the amount of time guards are had to bring people in under the section. But very few of them turned into applications actually for involuntary detention. And I'm on the Human Rights Committee of the Guards, and I meet with the Guards. And the Guards are doing it out of compassion because they don't know. It's not necessarily that people are psychotic or floridly psychotic, because very few of them actually turn into involuntary admissions. And I suppose, Frank, what I think is about the authorised officers is it shouldn't be voluntary. It's badly organised by the HSE, and it hasn't been organised properly. And we can't not do something because the people who are supposed to do it in law, the law isn't bad. The law hasn't been put into place properly and resourced properly. And this has been going on a long time. So I do take the point, but in terms of the new Act and the idea that an authorised officer should be the person, let's just talk about a modern society. It shouldn't be a justice force or a Garda force that's picking someone up for health. It should be a health practitioner, a person who's trained, who understands. But if we don't have enough of them, and I do understand that, I know from working in the services, and the service that you work in, it's one of the busiest services in the country, but the idea that we're going to do a different thing, we're going to do possibly the wrong thing, because the people who are charged by the state to do it properly aren't doing it, to me isn't acceptable as a regulator. So we're very strong on the idea of the authorised officer. And now if there's a transition to it, that's absolutely fine if there's other options. I also wanted to say about this Act, I genuinely don't buy into the idea that the current Act, which is advocating human rights, which is trying to align us with the different UN obligations, that somehow it's going to create a huge problem. But what I do want to do is make sure, and we said this in our submission to the Oireachtas, that where there's a lens looking at this, a lens of experience and compassion, that we do have to take that into account. And in terms of the department, because it's the early stages of the Act and reporting, so it's really important to me that we as a group of people who are passionate about mental health, that we make sure we have the conversations to do the right thing and there's no unintended consequences. But there is definitely no one at this moment in time who has the ultimate knowledge around what will and won't happen. But at the same time, I know from listening to my colleagues, because we have a lot of different professionals who help us on the tribunals. And the tribunals is honed over the years by their expertise, kind of feeding back in. So I do think it's important that if we have a cohort of people who are experts by professional, including Frank, the different people on the panel, the different doctors, that we do need to listen to that and make sure that we don't accidentally have unintended outcomes. And I absolutely appreciate that.
Thank you. And
Sorry, in relation, if you don't mind, to the AOs as well. Like it's great if you're for it or against it, but there's not enough of them. And the report that came out from the subcommittee yesterday just said, okay, so we need resources, but we'll resource them and that'll be fine. But they're not going to resource them and that'll be fine. From history, if you look back at the HSE for servicing mental health, they don't do it. We haven't had a mental health directorate, national mental health directorate, since 2016. CAMS is completely overrun. There's no beds for kids. Kids are still being admitted to adult wards, which is completely inappropriate. And, you know, Niall Muldoon in his Children's Ombudsman said that the new Act says children should be cared for in an age-appropriate environment insofar as practicable. And he was saying if we continue this way, we're legislating it into practice. So he was calling for us, he said we need to force the resources to be provided now. So I thought that was a really clever way of doing it, that we need to say, you know, I mean, I've been writing about mental health for way too long, obviously, because it just feels like we're having the same arguments over and over again. Kids are still being admitted. People in crisis are still going to A&E. They won't fund the AOs. They won't in time for the Mental Health Act.
There's parts of this country
Can
that
I
have
come
it
in?
perfect. If we could just pull it together and make sure that each area gets the same resources.
Yeah, that would be great. And
that's a very good point, that I suppose we can write whatever legislation we want, but how's it going to work practically, and is it actually going to be resourced? And Dr. Naughton, you want to come in there?
Yeah, I suppose there's just two things about the AOs, and I understand, like, if you look at the Act as it currently stands, so there are essentially 4 people who can make an initial application. So a guard, which is usually in a very acute situation, family member, an AO, or a member of the public. Now, where I work, a member of the public is often somebody who works in the hostel or the shelter, and they will make the application for me when somebody is unwell. So how it works is they see the person, they determine that they're unwell, and they would like me to come and assess them on that basis. And then I come and see them, and then I only based on what I see at the time and assess at the time, can I then decide, I think this person does require an assessment for involuntary admission, and make the application. So I think that if you're talking about, and I completely agree that there are situations where family members do not want to be involved and would be happier not to be involved, or where I'm working, there are no family members available. And I mean, I do think there's a place for an AO in that area, but I also think that making it solely the provision of AOs would be very difficult to manage. And I suppose I'm always conscious in terms of resources and services that if you look at where is our money best spent. And I think, I mean, I was speaking earlier today with Dr. Karen O'Connor, who's been involved in the early intervention and psychosis service. And I suppose another service that we have, thankfully, in Cork are the home-based crisis teams. And these are 2 excellent new services that have come on board. And certainly talking to local GPs in the area would say that certainly since the home-based crisis team has been available, they're involved in far fewer of these involuntary admissions, and it behaves as a bridge between the hospital, and it's a service, a team, a multidisciplinary team, all the things we're talking about, that can come to someone's house and engage with them. And again, the early intervention and psychosis team, which has had 3 pilot areas in the country, and there's a really, really good document on the model of care, which really says everything that we talk about here. And I mean, within Ireland, if you think about a first episode of psychosis, every year about 1,300 adults and 230 adolescents suffer a first episode of psychosis. And an awful lot of them will wind up hospitalized on their first episode. And their trajectory and their pathway, it's critical that they get the care they need at the time, and they don't have a prolonged period of untreated psychosis. And there's been a really good piece of research that's just been published, and it's come out in, I think it was April, in the American Journal of Psychiatry. So it's Irish Health Outcomes in Psychosis Evaluation. And they looked at over a 20-year period of 117 people who'd been involuntarily detained between 1995 and 1997. And they found that prolonged periods of untreated psychosis resulted in far worse outcomes in terms of symptomology, in terms of functioning and employment status, and in terms of quality of life. And if you look at the early intervention and psychosis teams, they really are about solving this problem. And I think there's looking at funding that going forward. And I think if I was, where am I going to put my money? You know, I think it's somewhere like that is where I'd be putting my money. I think that Frank has spoken very well, is obviously very experienced. And if we had authorised officers, and a lot of them are social workers, mental health social workers, and they're fantastic around family support. But as he correctly says, and I've checked this myself with 3 different people, there are currently no authorised officers working in Cork. And I hear what you're saying about we can't make the legislation based on what we don't have. But the reality is, I think we'd be far better served looking at things like the early intervention and psychosis teams. And I think, you know, if you look at, for instance, they have just done, I think, a report on their activities, and they have found that like over 75% of the people that they're working with continue to engage with them and attend their psychosocial appointments and are seen more or less weekly. And it's a dedicated team with lots of professionals, multidisciplinary, flat hierarchy, and they see people for 3 years. And I've referred several patients to them. And one young man who, you know, was basically living in the woods, you know, in a state of dire neglect, very unusual behaviours. I was referred to him, and I only checked up with the consultant today, and he's doing fantastically well. He's accommodated, you know, he's attending his services, he's going to training. But if he hadn't gone to them, or another young man who might not have been involuntarily admitted, then they are the ones who will wind up in states of dire neglect. And I suppose I'm just very conscious that, you know, when you work in homeless services, what you are seeing really is people who don't get the early intervention, who don't get the treatment, who disengage from services and are not followed up. And I think we need to just build that continuity of care around these very vulnerable people. And I suppose that's just, you know, and I do think if you were to look at the early intervention psychosis model of care, and I think the home-based crisis team model of care, and I think we, particularly in general practice, but I think all of us, you know, we need to look at mental health, as you say, you know, particularly with, it's the first presentations are often in adolescence and early years, and it's that kind of public education around what it is. And as you said there, June, taking away the stigma and the fear. And, you know, I think there's huge benefits will be gained. But the flip side of that is, I think as things currently stand, there will always be a time where we will require some mechanism for people who have lost insight and yet are not so acutely unwell that they're an immediate danger to themselves or others. So do we just simply wait while they deteriorate in front of us? And I'm really conscious of that whole idea of right to treatment. So I would, you know, I think that it's, and as you can tell from everybody at the panel, and I think it's fantastic to have all the diverse opinions, because it is a really complicated area. Nobody has the right answer to this. And I can have a very different opinion to somebody else, or even another GP working in homelessness. And we do have kind of conversations all the time. There is no perfect answer to this. And that's why we need to kind of trash it out and talk about it. But if you don't take all the perspectives, as you've said earlier, you may wind up in unintended consequences of what is fundamentally a very laudable aim. You know, we all want to respect human rights, but we have to think about people's right to dignity, to privacy, to treatment. And I think allowing people to suffer in an untreated state is not something that sits well with me.
Thank you, Anna Marie. Some really relevant points there. And I think you also pointed out that we have a very reactionary medical model in Ireland, physical and mental health, that we let people deteriorate to that level when they do need crisis intervention. And even again, just looking at termination of pregnancy, like involuntary detentions, if we want to reduce the number of people who are involuntarily detained, we need to stop them becoming that unwell in the first place. We need to resource services. We need to provide those community services and the pilots that you mentioned there. And again, this year we heard that there's going to be a record mental health budget. We hear this every year, myself and June. It's still 5 to 6% of the overall budget, far less than 10%. And will they actually spend all of it? They never do. They never manage to get the staff. But we have a lot of questions coming in from those who work at home. But I do know that some of the panel members, again, want to come in very quickly just on that particular point. Ber, I'll go to you quickly, and then I'll go to John and to Lurkin.
Thanks so much, Priscilla. Yeah, just really quickly, one of our members, A Lust for Life, last week launched a schools wellbeing programme, and there's definitely a lot more talk happening about early intervention and prevention and speaking about wellbeing. Imagine if we got to a place where young people, you know, as soon as they started having those intrusive thoughts or thoughts about wanting to self-harm, that they realised they could reach out for help, you know, that they didn't need to go through that. And the state is up in front of the UN Committee on the Rights of the Child in January. We were part of the pre-session there last week, and with the Ombudsman for Children, and one of the things that the committee were really concerned about was the high rates of suicide with young people and high rates of self-harm with young people in Ireland. So it was interesting to see that they really focused in on that. And just the other point about the AOs, the authorised officers, we partnered with the HSE's Mental Health Engagement and Recovery Office last year for public consultations, and this year we did a regional roadshow, and we were in Cork and Kilkenny, Sligo and Maynooth, and it was for people with lived experience and their family, friends, carers and supporters. And across the board, everyone agreed that they want a fully resourced authorised officer team across the country in all CHOs, and they want them to be that support for the family, for the person, that kind of go-between, you know. So it will be a hugely important role, and I think it's something we have an opportunity now. You know, there is money there, there is funding there, there's the political will. We have an opportunity to be a world leader now. So instead of kind of thinking about the resources that we don't have, it's like, let's aim for what we can have. And I was actually mentioning Karen O'Connor and early intervention and psychosis earlier today in the Disability Matters Committee, because there's some really great national clinical programmes. As John said, there are some great things happening across the country in different pockets and in different silos. And if we could have that national director at, you know, reporting directly to the CEO in the HSE, someone to bring all of those pieces of the jigsaw together in mental health reform, we do think that would make a huge difference to services and people providing the services.
Thanks, Bert. John, did you want to get in there?
No, I just wanted to emphasise, the AO thing doesn't have to stop all the early intervention. John O'God's have been doing intervention. There's some serious people in Ireland who've been doing early intervention, and that it's just so critical. And if you think of all the people that are involuntarily detained for the first time, the resources that should be put into them, because to make sure as much as possible you don't have your second or your third relapse, I mean, they're huge resources, and people need to understand we simply don't have the right amount of staff at the moment to offer that huge amount of care. And I don't buy the thing of we're in a world market, we're competing. I don't buy that, because you need to make sure you have the resources in place, the buildings, the people, supporting the clinicians and putting the team there at once. Very often what we see in certain teams is, and look, I want to be clear, this is a reforming piece of legislation. I think we have the people, we have the ingredients. But what we see in certain teams is once the consultant leaves, the team can collapse like a house of cards. Now, maybe that's stopping, but I definitely noticed that if you have the consultant in place and you have the full team in place, you have a much better thing. But early intervention, absolutely 100%. Just to say, if you have VHI and private health insurance, you have a better chance of early intervention than if you don't, and I think I just have to say that.
Sadly you do, and that's unfortunately very true for a lot of other health conditions, and we know that nearly half of the population have health insurance, and obviously it would be interesting to look deeper into the data there on the outcomes of those patients who do need mental health support who have private health insurance. But Larkin, I think you want to come in.
Yeah, I suppose, June, you said you've been at this too long. That must make me an absolute relic altogether. But, I mean, you know, in decades of psychiatry, I'm hearing the same drum banged about how we're not getting the right proportion of the health budget in mental health. And it has remained stubbornly low. And I know there's some extra funding this year, but it's not going to go nearly where we need it to. The problem is that the AOs, the authorised officers, are going to cost money. They're going to cost a lot of money. Now, do we abandon building the new CAMS unit somewhere or other so that children wind up going into adult units? Do we not fund a new multidisciplinary team somewhere where it's badly needed? And the reason I'm making that particular point is because I think there are some fantastic community teams and there are some very under-resourced community teams. This is something John and I would have discussed before. And I suppose, speaking from my own experience, I haven't had an inpatient in about 4 months. And the reason I haven't had an inpatient in 4 months is because I have a well-resourced, well experienced and well qualified community team who have built relationships over a number of years. And it keeps coming back to what people are saying. A lot of this is about relationships and you know, seeing the person in their community. There are places that aren't that lucky. They don't have half of what they need. They're overstretched. We're not able to hold on to staff because people are overstretched. We don't have the teams. We don't have the consultants. There's still, you know, nationally there are 800 plus consultant posts empty in various specialties. One of the difficulties we have is, as a drum we keep banging, is that all consultants should be specialists. And that is an ongoing problem. They aren't all specialists. And a lot of locum consultants move around. And as John says, sometimes when they move around, the team comes undone. Or the team doesn't form a cohesive whole because they know, oh, this person's here 3 or 4 months. So we need people appointed in jobs. We need to hold on to good people. But we need the resources to standardise what we've already got in the country. Because experience has shown, it's not just my own team, with other teams as well, when you have a well-resourced team who are dynamic and prepared to get out there, things happen and things work. And you can develop relationships. Now, if we are to sacrifice that to bring in 400 or 500 authorised officers, I think that would be a mistake. However, I'm not saying we shouldn't do it, because I think we should have the authorised officer idea is extremely good in the sense of having somebody who will be dedicated to that job, who will be able to liaise with the families, the patients, and so on. Putting it purely down to authorised officers when we don't have them is going to be a problem, certainly. The other issue is that if we create the authorised officer, and John quite rightly pointed out, this shouldn't be a tack on to somebody else's job. We are now creating a whole other discipline. Where are we going to get them? We can't fill the disciplines we have. So this is the practical difficulty I see with the authorised officer idea. In principle, it works very well. If you have plenty of authorised officers, 24/7, when the Gardaí picks somebody up, they're able to get someone very quickly to see them, so they're not languishing in a cell while they're in a completely unsuitable environment. It's all in principle great. I think the practice of it is going to be very difficult, and if we decide to go down the road of funding it, we may well wind up underfunding other important resources in the community, which we've seen are necessary.
So that's obviously something policymakers need to be aware of. And obviously, you both have the same aims, yourself and Bert. We want to have the best outcomes for patients, the best experience for patients, and obviously for as few people as possible to have to be involuntarily detained. You just pointed out there how well your service is working, but we know the huge geographical inequality around the country. But I'm just going to go now to take some questions from those who are at home from the audience there.
So we've had a number of questions, and thank you so much to everyone in attendance who sent them in. Unfortunately, we won't have enough time for all of them, but there's some very broad themes that are coming through in a lot of the questions. And I suppose a general question, based on a number of comments that have been sent in, would be, do the panel have comments on the balance of human rights versus involuntary admission and for someone who needs help? And this is also in the context of the UN CRPD, which is coming up in a lot of comments there as well. And just to add on to that, maybe if there's further comments on the use of advanced healthcare directives. I know our contributor Rosie Wilson had a specific question on that, and that has come up as well. So I suppose that is the balance of human rights versus involuntary admission, and the need for treatment in the context of the UN CRPD and the use of advanced healthcare directives.
Okay, yeah, that's a topic that we want to get to as well, advanced healthcare directives. And we actually have a little video clip there from Brian just about that. So in answering those questions, we might just play that clip first, and then I'll put it to the panel to discuss.
So just in terms of advanced healthcare directives, there was a time, probably following my third admission, when I wrote to my psychiatrist, and I kind of says, look, I'm never going to be, this is only after my third of 7 admissions, I said, I'll never be in hospital again because I have myself sorted out now. But if I happen to have to go to hospital, I don't want you to use any medication. I don't want to take any medication, because I was very anti-medication at the time. So that was a type of an advanced healthcare directive. But of course, it wasn't really appropriate, because I need medication. I need antipsychotic medication when I'm unwell. It's the first stage of the treatment. and I'm aware of that now. So that would be my only experience of writing to the doctor. And then, in all fairness, for 1 or 2 days, they didn't put me on any medication when I was in the second time. But eventually, they put me on medication, and it was the right thing to do. So it's in hindsight when you notice these things. I was very angry when I was a patient, and that anger is gone now because I realise I got very good treatment over all that time.
So those are the words of Brian McNulty again. Thank you very much for, I suppose, putting that issue just to the fore there, and coming in from the audience, a lot of questions about that. Advanced healthcare directives marrying, human rights legislation, respecting the rights of the patient. And also from our earlier video, Rosie Wilson had some specific questions which are in line with what's coming in again from those who are watching at home. So I'll just call out that, and then I'll put it to the panel really to talk about this. So Rosie asked, how can you categorise such a motley selection of the population, i.e. those of us who are not are involuntarily admitted, as unworthy of the protection of capacity legislation? Because we do know one of the issues with the new legislation that is coming in is that it should be in line with the assisted decision-making capacity legislation, which still hasn't been enacted. Rosie also asked, are there statistics about mental health patients that are admitted being a danger to themselves and others? So we know abuse happens in 1 in 4 households. Should these people also be excluded from legislation? She also asks, if I am involuntarily detained and my advanced healthcare directive is disregarded, are my physical health and end-of-life wishes, by far the major part of my advanced healthcare directive, also ignored? And then why should legal and mental health capacity in advanced healthcare directives be doubted because of a mental health episode? They are separate issues. So I know that's a lot to take in, but again, what are your thoughts to the panel? Going to you first, John.
Well, I can tell you what the Act says at the moment, the bills in terms of it, is that at the moment, people under the Advanced Healthcare Directive doesn't stand for people who are involuntarily detained, only relevant to their mental health treatment. So one of the questions she was saying is about the physical, so it's not relevant to that. Obviously, the position of the Commission is there should be parity, but at the same time then you're trying to balance in terms of the risk in terms of them. So if someone is compos mentis, has full capacity, and I make my advanced healthcare directive and say, I never want to be put on an antipsychotic drug, then you would think that would be, I'm compos mentis and I'm saying that. Well, under the current legislation, if I need the treatment, I will get it. It'll be overridden. Now, in fairness to the Minister and the Ministers and Health and everyone, they're really trying to balance this. They're trying to, figure it out. Kind of in real time, and I know the Minister and the AG, they're trying to look at it and balance it. Now, so we have, even better brains than me, people are trying to balance it and how you figure it out. The position of the Commission is there should be parity.
That's fair enough. And Ber, what are your thoughts?
I'll echo that. We've been advocating for years that the advanced healthcare directives should be the rights to have your will and preferences respected should be extended to people involuntarily detained under Part 4 of the Mental Health Act and also the Criminal Law Insanity Act. We've been working really, really hard on this all year. We got a human rights analysis piece done on the heads of bill to reform the Mental Health Act this time last year, and have been liaising closely with the ministers and their officials. And as it stands, and I think Brian's point was excellent, if you've been, usually when you've been through a mental health difficulty or in hospital or inpatient, that's when then you think about, if it happens again. So every other person at the moment, every other single person has the right for physical treatment to refuse or consent to treatment, to have their will and preferences respected, except people who are involuntarily detained. Now, the government are bringing a partial amendment to that, but it's creating this discrimination within the categories of people involuntarily detained. And like that, we've all been really strong. IREC, the Mental Health Commission, Decision Support Service, all of us, all of the Taoiseach, everyone agrees that this is discriminatory, but there's a piece about who doesn't want to own it, and the Department of Health are saying that it will be dealt with in the mental health reform of the Mental Health Act, which is why we're saying we have the pre-legislative scrutiny report now. The AG is working on the bill. We need it January 2023. We need Minister Butler to be bringing it into the Dáil. And just to say about the UNCRPD, because it links. So if you have enduring mental health difficulties, you have psychosocial disabilities. So you have rights under the UNCRPD. Article 12 is the right to legal capacity, and Article 14 is about deprivation of liberty. The Irish state has reservations on both of those articles. So when we ratified the UNCRPD in 2018, we went, we'll ratify that, but, these two pieces that might affect people with mental health difficulties, we'll wait and see. And there's also the optional protocol, which is the complaints mechanism, which hasn't been ratified. So we were in front of the Disability Matters Committee meeting this morning speaking about this exact thing, that there are concrete steps that the government can make now to show their commitment to actually implementing the UNCRPD, and that would fulfil rights for people with psychosocial disabilities.
Thank you. And just actually to insert my own comments there, I know people think that it is only mental health where your wishes can be overridden for an advanced healthcare directive. I know in my own case, in physical health, they were actually overwritten to save my life and my child during childbirth. So just to point that out, and people who are Jehovah's Witnesses, sometimes they need an emergency blood transfusion. So there are some elements in physical health. But you made a very good point there as well. If people sometimes feel that they have to override those healthcare directives in a mental health situation, that doesn't mean that they shouldn't come back to the plan. Doesn't mean they shouldn't do it for another visit, that there's other elements of it that they should try and adhere to it as closely as possible, so that we can kind of marry that in together.
And there was one of our regional roadshows, a couple of people were speaking to us about the advanced healthcare directives, and in the UK, some people might, when they're well, put in their advanced healthcare directives to say, if I'm going through a crisis, I might not want you to talk to my family, but now that I'm well and that I have capacity and that I can make these decisions, I'm putting it in writing that I do want you to speak to them. And like that about the medication, this treatment works well for me, or I have side effects with this other treatment. While I'm well now, I'm with my capacity, I'm putting this in my advanced healthcare directive, knowing that when I'm unwell, I might say that I don't want those things. So again, there's the advanced healthcare directives are there. They reduce readmissions. They're an empowering piece of a tool, that we should be using and that we can't exclude some people from.
And it is a natural change in healthcare and in society, shared decision making, being more involved in our care and in those decisions. That's happened naturally in a number of years, and even in over the 20 years since the legislation was put together there. And June, sorry, moving on to your thoughts there on that topic.
Yeah, advanced healthcare directives are really important, and they should definitely be available for everybody. And people who are involuntarily detained, as well as there should definitely be a parity in both. But you're right. So there are times when, for example, if you're on an emergency, if you've been knocked down by a bus and you can't give your capacity for treatment, that it overrides it. So it's not just mental health; it's physical health as well. But advanced healthcare directives, especially as Blair said,
that's the new. So the assisted decision, once it's implemented, that's what it'll be.
So,
yeah.
But as well, what you said was, it was so important that when you're well, you can write down what your wishes will be for treatment, and that's a really powerful thing, and not just in mental health, for physical health as well. If you've got a long-term health condition and you know that what happens when you deteriorate, whether you be resuscitated or not, all those kind of things are important. And once that's written down in black and white when you're well, it makes things much easier for treating clinicians, but also for your family, because they know that's what you wanted, and what you wanted will be carried out. So
Thank you. And Lurcan, your thoughts?
Yeah, I'm amused at Rosie describing it as a motley bunch. And I suppose it's, do you know what, though, actually, it's really important. Everybody with mental health difficulties is different. And I think she's hit the nail on the head with that. It's not one size fits all. I think that's really important. And this is where person-centred comes in. I think the other important thing about advanced healthcare directives is, it's not black and white. There can be many components to an advanced healthcare directive, and you may only be in a situation where you have to disregard one part of that. And Brian mentioned in his first video that there will be periods when he knows he's not able to do what he needs to do himself, and at that point he needs someone else to take over. So there's no reason why the rest of the Advanced Healthcare Directive can't be respected. And then when things improve, as you say, you get back on track. So I think people sometimes feel like it's an all or nothing thing. It really isn't, and there can be many components of it. And I remember a lady I had many years ago, and it was before people even talked about Advanced Healthcare Directives, and she was pregnant, and she wanted to talk to me about her care during pregnancy. And she actually came in fairness to her, she had gone away and she had looked it up, and she said, if I become depressed during pregnancy, I want this antidepressant because I've looked it up as the one least likely to cause a problem with the developing fetus, blah, 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 blah. And then she said to me, and I become a right bitch when I'm pregnant. And I'm telling you, I will beat you around the place, these are her exact words, to put me on X, Y, and Z. I don't want you to listen to me. What we've drawn up in this document is what I want. So I signed it, she signed it, the GP signed it. And I know it sounds a bit dramatic, but they were her exact words. And the point about it was, she knew herself. She knew herself better than I did. And she knew, I am likely to do this. So this is how I want you to work around it. So, I think they're really important documents, they're a really important concept. I think the notion of people taking more responsibility in their healthcare is becoming really much more important. And I mean, we do talk about empowering people, we talk about autonomy, we talk about responsibility. So we're moving away from that paternalistic notion of bring everybody in and look after them. That's not what we do. And even in community mental health care, it is about getting someone to the best they can be, but also letting them live their own life. So we can't have it every way. You can't say we want to look after you and at the same time kind of go, but we want you to take responsibility. That balance is important. And I think we need to listen to what people have to say.
Thank you. And we don't have very much longer left, but I'm keen to get to the rest of the panellists on this. Frank, I'll come to you.
I'll be very quick. There were two elements to the questions that came in. One was about human rights. How do we balance that with mental health legislation? Well, it isn't that hugely difficult. Lorcan made a very important point. Maybe people didn't pick him up. 100 people who have mental health issues, 90% will deal with that in the community, GPs, primary care. 10% of those, the GP struggling, and they're referred to psychiatric services. And that 10% do well in the community. 10% of that 10% may need involuntary admission, may need an admission to psychiatric hospital. And it's only 10% of that 10% who are involuntarily detained. Clearly, you can have young people, early intervention psychosis. We live in a libertarian view. 40 years ago, we had the church Christian ideology. Now we have this human rights ideology. Most of it is perfectly sensible. There is no issue with the involuntary detention criteria. That still adheres to human rights legislation. The expert review group decided to up the ante a bit because the expert review group, it didn't have any disciplines, didn't have the authorised officers asked to be part of it. As far as I'm aware, carers' voices were not heard. I'd be fascinated to hear what carers who have a relative at home or who are worried about them because they're living in homeless services. John from the Mental Health Commission talks about you do well with private health insurance. Actually, if you have a severe enduring mental illness like schizophrenia, number one, you won't have access to private hospitals because you won't have the funding. But can I just let me finish? But the point is the follow up. Our community mental health teams follow people up. My CPN colleagues visit patients on a weekly basis. My colleagues see people in the community day in, day out. Private health insurance will not get you that resource. Our buildings are very small and crammed. Vision for Change closed down all our psychiatric hospitals because they were crumbling. It didn't ensure that we had some approved centres of a quality for the slow recovery patient. What have we done? We are spending a fortune to private hospitals to provide that. They are taking on these slow recovery patients. So you have to get a certain fairness into that. The other thing is, in terms of advanced care directives, there's a tiny, tiny percentage of patients who might say, I never want ECT, I never want ECT. If they're unwell and nothing else works, you'll have family members, you'll have a busy acute unit saying, what are you going to do about Mary? She's not eating, she's not drinking, she has an advanced care directive that says never ECT. What do we do? Do we put Mary in a room and leave her unwell and leave her not eat or not drink because she's not communicating? It is completely naive not to allow mental health professions and family members to have some input into those 10% of the 10% of the 10% and not have this. It's not human rights if we don't have this ideology. We all have to sign up to it. Human rights means what Amnesty International say. You have to get the balance, and that's what some people have said, what our colleague down in Cork said. You get the GPs, you get the family members, you get the lived experience of people who are articulate. There are people we discharge every day of the week, and they still lack capacity because they have such chronic issues, moderate intellectual disabilities, or they may have a propensity for addiction. They struggle all the time, and John is totally right. It's the CPN who knows them. I've worked in the same job for 15 years. I see the same patients every 3 weeks. For 10 years, I see the same patients. I help them manage their finances because it's all gone by 3 days. I steal their bills and I pay them. My human rights colleagues would say, what are you doing stealing their bills? Because I don't want them cut off. And of course they're happy when I pay the bill. But at the time, their wishes and preferences are, I want to spend my money on clothes. 6,000 books, 4 copies of the same newspaper. That's what happens when people are untreated, and this naivety that we respect wishes and preferences. We respect wishes and preferences of people who have capacity. It is crucial we get this right. Apologies.
But no, thank you very much, because it's very important that we do hear that side and that this is why legislation is needed, but also from the side of, say, even Burr, it's very important that we scrutinise it and we do ask those questions, and can things be made better? They always can. And finally, I'm going to come very quickly to Kate and to Dr. Nocton.
Very quickly, because I'm going to defer to the practitioners upon this table and just say, as my classic understanding is, that human rights lose all of their integral integrity if you do anything other than balance them. A hierarchy cannot be allowed to recommence, because then you have the ultimate challenge of a determination of a hierarchy of rights that is, number one, contrary to any understanding of the application of human rights. But I absolutely want to go back to what Rosie said, which is she unworthy of the protection of human rights? And by being human is the key word here. Her entitlement to human rights is part of her humanity. And so the simple answer to that is no, but it is not simple or easy.
Certainly not, and obviously with the guards, they have to respect that and to try and to make sure that the public do trust them. So that is something that is constantly under review and scrutiny, isn't it? Very much
It
there.
absolutely is, and the model of training is the least intrusive measure to achieve the goal desired, proportionate, necessary, and that goes to the core of the guarded decision-making model, with human rights at the very centre of that. That training, I think, has improved the internal integrity of decisions made in very, very complex situations, and often at very difficult times in people's lives, because that's the nature of an emergency service.
Absolutely. And just finally, very quickly to you, Anna Maria.
Thank you very much. I suppose my attitude to a lot of this is informed by a lecture I heard once by Professor Brendan Kelly, and it was titled Dying with Your Rights Intact. And he told the story of a gentleman who died in squalor in a flat in England, and whose brother said, could something not have been done? And I suppose, and we, extreme cases make hard law. I totally appreciate that. But I suppose it is all about balancing rights and your right to treatment versus your right to choice, and where capacity comes into that. And I'm certainly not an expert in this, but I think if you go back to the conversations that we've had, and I love the story about that, that pregnant lady being very frank and very clear, it is all around the relationship building. It is all around the continuity of care. And I think what was very clear from the 2 videos we saw from Rosie and Brian is that idea of being seen and being heard. And whatever the legislation and whatever the recommendations are, at the end of the day, it will be a practitioner and a service user or a patient or somebody who's unwell, attempting to build a relationship, attempting to help somebody to get better. And it is around that day-to-day conversation, that relationship building, that trust. And I suppose the idea that we are none of us in this job to try and make things worse for people, and I think the idea that people come into healthcare with the expectation, quite rightly, that they will get the best care that can be provided them, taking into account their will and preference. It's not an easy, there's no right and wrong, or there's no very clear, simple answers. So I think it is all around having those conversations, that interaction with the person that's your patient, the long-term view, and constantly questioning, are we doing the right thing? Is this what you want? Explaining, having the conversation. And I hear what you're saying about the more vulnerable people, people who maybe not as articulate, who might have more difficulties. That's the challenge all the time. You know, it's our job to interpret what's going on for people who may have difficulty interpreting it. It is all about the ongoing conversation, the relationship, the trust, particularly for people who are very vulnerable, who are very distressed, and who suffer with, you know, severe and enduring mental illness.
And Maria, thank you so much. I think you've summed up the key issues at hand tonight, and I really want to thank our panel for their varied, insightful views and for opening up this discussion. And hopefully this discussion will continue, because I absolutely think it does, among policymakers, clinicians, healthcare workers, patients, and very much the general public as well. So just to wrap up, I'm going to hand over to Dr. Maeve Doyle, the Director of Communications and Public Education with the College.
Well, that was a great evening, really stimulating. I hope Ber and Frank will happily not bury the hatchet in each other and have a little coffee afterwards. Oh gosh, will they exchange pens? But firstly, I'd just like to say I think it was really stimulating, and it's great when there is a difference of opinion and so much evidence and so much lived experience and so much practitioner experience. I'd just like to thank Priscilla Lynch, our health journalist and clinical editor of the Irish Medical Independent, who really ably chaired and summed up everything for us, which was great. She stopped it degenerating into a bun fight, which was great, and she managed to collate all the questions that came in on Zoom, which was wonderful. I'd also really like to thank the panel, because I know it's quite a commitment and it's a daunting topic and it's quite complex. I'd like to thank Dr. Lorcan Martin, our own Vice President of the College of Psychiatrists, Ms. June Shannon, Medical and Healthcare Journalist, Mr. Frank Brown, Principal Social Worker and Authorised Officer, Ms. Kate Mulcairns, Executive Director, Legal Compliance of An Garda Síochána, Ms. Ber Grogan, Policy and Research Manager of the Mental Health Reform, and Mr. John Farrelly, CEO of the Mental Health Commission. And a particular vote of thanks to the lived experience, I think I'll call them actors, Brian Mulcairns and Rosie Wilson. I think you were very brave and also very succinct and really put a dichotomy of views very nicely for us. And finally, our own department, Andrea. Oh, sorry, Anna-Marie. I'm very sorry, Anna-Marie. I keep forgetting you because you're not right in front of me. But thank you so much for the GP's contribution. I'm married to a GP. I'd be shot if I didn't mention him. So thank you again, particularly to our own department, Andrea, who is the manager of the External Affairs and Policy Committee, and ably assisted by Karen McCourt with the lovely voice, and Ian Rice, who did a lot of the technical stuff. So thank you very much. Thank you.